It's always good to see master surgeons. Very impressive, Sachin and Parag, and a very impressive program. I want to just give my last round of applause to our local host, our organizers, all the AV guys, all the video guys. It's a very great job. Thank you very much. And especially Sachin and Parag. So let's do this quick. I'm sure everybody's hungry. I'm sure everybody wants to see the video of Christian doing a double level. So we're going to kind of just run through the panel. So to me, tackling the varus knee is what I do for a living. And the Indian knee is, everyone's saying it's constitutional varus. I think the American knee is constitutional varus, which is 3 degrees. The Indian knee is more than constitutional. It's super constitutional. It's about 5 or 6 degrees of native varus. Every knee we've seen today that's a normal knee x-ray, a 20-year-old, is 6 degrees of varus. So what's our indications of osteotomy, unilateral knee, and what are we telling our patients? We're going to talk about this tomorrow in the program as well, so I'm just going to tackle more. We definitely see, because of our European colleagues and also our Asian colleagues, that North America was behind in osteotomy. We're definitely seeing a rebirth. We all love unis. Unis are great operations, quicker recovery, preserves the cruciates. It kind of gives you more of a forgotten joint. And then robotics with new technology has made it better and quicker and the like. Total knee is a great operation. I usually come here for the last 15 years and bash total knee. But total knee got me through college and paid for my medical school. So I really can't be that bad about it. But obviously, the cost, revision burden, there are a lot of issues we'll talk about tomorrow. So I want to go through cases. 35-year-old, had a history of an ACL, BTB with a meniscectomy, failed conservative treatment, pretty good motion. ACL is doing okay for being 10 years old. Let's run down the panel. Who does arthroplasty on this panel? Okay. Who does total knees? Who does unis on the panel? And who does osteotomies on the panel? All right. So this panel is going to be very different than the panel tomorrow, where everyone's going to say total knee, total knee, total knee. Let's run down the panel. What would be the youngest age you would do a total knee on? Matan, you want to go with you?
40.
Yeah, I've done that at about 38 for a RA.
For OA, I'd probably recommend 45.
45 to 50.
Same.
I don't do totals, so I'm going to stay out of this one.
Youngest around 40 in inflammatory arthritis.
Right, so I think that's a pretty critical difference, right? I don't think really age is really the factor, it's really more diagnosis that we're all kind of saying, a rheumatoid knee, post, a TB knee, kind of, a rare Roman knee. But post-traumatic arthritis or OA, we're probably less inclined. But if it's really post-traumatic arthritis, tibial plateau, that could change. Likewise, what's the oldest osteotomy you would do?
It's the same answer. If we rule out inflammatory arthritis, 60 has been my limit.
So osteotomy 60
but
years
the
old?
older the patient gets, the more inclined we are to offer a replacement.
I understand that. The answer is what? Just give me the answer. What's the oldest osteotomy you've done?
I would look into the physiological age. I've pushed it up to about 58 till now, in a good pristine other compartments.
Jason?
Probably about 55.
I have no upper limit.
It depends if they want to run. So the oldest I've done is 58, but over 50s are only in people who want to run.
Yeah, no upper limit. It's physiologic.
For females, somewhere around 50, and for males, somewhere around 55.
Yeah, I would agree with that. And since I think it's different for males and females, I think activity level matters. But really, I don't put an age on it. It's physiologic. It's physiologic. So let's. Last question. Dick Scott, one of my father's, created uni criteria, the Scott-Cozen criteria of uni compartmental. He said, you never wanted the uni to be your first arthroplasty or your last arthroplasty. That's one of his lines. Can you do unis on young people, or should it be only an old person operation? So young or old? Or doesn't matter?
Doesn't matter.
No, age is not a criteria. Again, a physiological age.
All right.
I think you can, I don't think age is criteria for that.
Not a criteria.
Yeah, activity. It's what they want to do.
Agree.
All right, so Dick Scott's wrong. I'm going to go tell him. I used to call him Uncle Dick. Okay, so let's see this case. As we talked about, exam is pretty benign. So has this, you can see early medial compartment failure, tibial slope, 6 degrees of varus, and you can see that osteophyte formation. You can see that OA in that compartmental overload. What would you do, Matan?
So we try and see the coronal scanogram. I'd offer a scope to the patient because the range of motion is restricted to 90. So there's something inside the joint that's restricting the range. And based
No, she's at full motion. That was, she had pain at 90 with a squat.
Fair. Could you move back to the coronal scanogram,
No,
please?
you have one, we have 10 minutes. We got to go through more cases. Go. What would you do?
Offer her alignment correction.
An osteotomy.
Yes.
Okay, would you do anything? Okay, fine. Next.
It's definitely worthwhile looking at a skyline view and looking at the patellofemoral compartment before you take a call on this.
Okay, so you care about the kneecap.
Yeah, because her pain and restriction of range
Her pain's medial.
could be even, okay, pain is medial.
Pain's medial, and your MRI of the patellofemoral joint looks crappy. Are you not going to do an osteotomy?
Even if it's pushing beyond a certain limit, I would preserve the joint and do an osteotomy rather than offer a uni.
Jason, what would you do?
I would probably offer her a osteotomy, but depending on what is her pain tolerance and how much does she want perfection? Because in the United States, if she is a high maintenance person who wants to be absolutely pain-free, then I may have her see one of my colleagues for a uni.
Yeah, I would discuss both uni and osteotomy with her and kind of gauge what she's looking for.
This patient for me is absolutely osteotomy and is absolutely not uni. So very dogmatic about that.
Mark?
Yeah, medial opening wedge, proximal tibial osteotomy.
And
So it's a post-meniscectomy medial compartment intra-articular varus. So preferably osteotomy in form of maybe TCVO may be much better because there is no extra-articular varus deformity here.
what would you do about the cartilage in the knee?
I would base my decision on a standing X-ray. If the standing X-ray is bone on bone, I would offer a UKR. If the standing X-ray is not bone on bone, which I assume in this case,
It's not.
I would just, depending on the reduction in the space on the standing X-ray, decide my amount of correction on the alignment.
That's a different question now.
And not do anything for the cartilage. I would correct, for example, to the Fujisawa point.
All right, so let's get there later. So we've decided the patient has a joint space. We're doing an osteotomy. All right? She's young, active, and has a joint space.
Have you exhausted the option of orthobiologics here?
What? We've done all that stuff. That's all bullshit. My father would not let you do that. Go back. Go do 10 push-ups.
Yeah.
All right.
So no specific cartilage treatment, just correct to the Fujisawa point.
That's good. So would anyone do an osteotomy on a young patient that has bone-on-bone contact on an X-ray? Raise your hand.
Yeah.
That's, still relatively uncommon in North America, very common in Asia. But I guess it depends on the young patient. Okay, next, cartilage. What would you do? Nothing? And then what was your goal of correction? Go down the line. Jason?
Nothing with the cartilage, and I'd probably correct to the lateral spine or just after.
Taylor?
Same, nothing for the cartilage around the lateral spine.
Yeah, I'd be having a really good look at the cartilage. I mean, if it's truly bipolar grade 4, then not. But if the tibial side isn't quite as bad, I'd certainly think about condylar restoration on the femur. And you said 2A Lockman as well. I think having a really good feel of the ACL. She's only 35. Need to do everything if you're going to do something.
Would you try dialing the slope doing an opening wedge osteotomy?
Yeah.
How effective can you reduce slope with an opening wedge osteotomy?
Me, not as well as I can a closing wedge. So I'd have this for me would be PSI closing wedge.
Mark, anything else?
This is somebody I think about scoping first, actually, to get a sense of how bad. I mean, you can get some idea from the MRI, but more from a scope. So I would think about a diagnostic scope first. And if I thought that there was a fairly isolated lesion because of the age and activity level, I would be inclined to consider an allograft in the U.S. because we have that available. But I would guess more than likely it would be osteotomy alone with no cartilage work.
Yeah, I mean, there's no harm in doing a osteotomy alone. I did an OC allograft and an osteotomy. Anything else to add here?
No, nothing else.
And I didn't touch her ACL. Her ACL was fine. And I tried to dial in 1 or 2 degrees of slope correction just to kind of, and you could do that. And you can see with this, this is a drill bit PSI system. So it actually uses drills. So you can completely corrupt or manipulate your hinge axis. And you can really dial in and where you put your posterior pins, and these heal. A, it's a small correction, but B, these heal very, very well because it's all drill bits and it's not a saw, and that's what it looks like. And you can also, it's also a patient-specific plate, so I can have my screws sprayed apart. So everything's all based off the preoperative template. So it's a really osteotomy in the box. All right, so let's do another one. 65-year-old, history of meniscectomy, failed PT injections, significant right medial knee pain, as well as anterior pain, has got anterior crepitation, full range of motion. We want to do an osteotomy on him? Anybody? Anyone want to do a total knee? Raise your hand, total knee. Would anyone do a uni? Do we care about the patellofemoral joint in a uni?
I don't unless it's in the lateral patellofemoral facet.
That actually looks pretty, the lateral patellofemoral doesn't look great on that merchant.
No, I'd open the knee up and see the facet myself.
So you'd be prepared for a uni, you'd say uni, possible total knee.
Isn't
Yes.
the key
You're-
the history, the anterior pain and crepitus that she had? She's got pain at the front.
I understand that the patient has a grind positive, but you would still confirm since you're anyways opening the knee up. I would also, sometimes we have patients talking about if they visit other doctors, there's chondrocalcinosis and you can see calcification of the lateral meniscus. That doesn't affect my decision
Yeah,
making.
I don't care about that at all. Anyone care about that? Look at that lateral compartment. Is that bad or is that good? That's pristine. So to me, the teaching point here is that everyone will have some MR findings of chondral wear of the patellofemoral joint, but this patient has symptomatic patellofemoral wear based off anterior knee pain and a grind. What percentage of total knees have anterior knee pain after a total knee? It's 30, 40%. Do we resurface patella or we don't resurface patella? Does it matter? No. They still have what? Anterior knee pain. So this is why, what would you do? I did this. He loves this knee because we saved the cruciates. Anyone do a bicom here?
Now, why did you choose not to do a total knee? She's 65.
Because he's preserved the cruciates. It feels like his own knee. My father will say, you'll never have normal kinematics when you take out the cruciates. You'll never get normal rollback. You'll never have a forgotten joint index. For a small deformity, now you can make the argument you don't have to do anything with the patella joint, but this is something,
So assuming this patient has lateral patellofemoral joint arthritis, this system still doesn't do anything to it, right? You haven't resurfaced the patella.
It was only on the trochlea. And also we know, based off total knee literature, that Amar now almost never resurfaces the patella. The incidence of patella resurfacing is actually going down, not up in the United States.
So hence the logic, once you open the knee up, if the patellar facet is bad and the trochlea is good, you can just go ahead and do a uni.
Great.
Whereas if the trochlea is bad, do a total knee replacement and resurface the trochlea as well.
Right, but then you don't preserve the cruciates. If you're a believer in unis, you're a believer in unis. Okay, let's get one real quick one. 56-year-old, mild varus alignment, medial knee pain, full range of motion, a painful squat, has 4 degrees of varus, early medial compartment wear. What do you do?
Conserve the patient.
You did all that. This is surgery conference. It's not non-operative conference. You failed. Next question.
Yeah,
Go down the
conserve
podium.
till my neighbor
No.
operates.
You're done. Next.
This is a tricky question because she's 56 and you see relatively the knee is preserved. There's no osteophytes yet here. It's more of
There's a little medial osteophyte. Look at close to the medial tibia. There's an osteophyte there. This knee's going down.
yeah, and no much of a mechanical malalignment. So I would again go with my colleague. I would probably preserve it till I see some radiological changes here.
So you're doing no operation.
For a 6 degrees of varus,
It's
I
about
may
5
scope.
degrees, yeah.
I may scope and rule out any form of
He
ganglion
already
cyst or
had a
something.
scope. Jason, would you do anything for this? What would you do?
Oh, you stole my thunder. You said he already had a scope.
Yeah.
So that was going to be my next step.
So a scope here, my dad would call surgical induced rest. That's the advantage of a scope here. Taylor, what would you do an osteotomy on this guy?
Yeah, I think it looks like uni and osteotomy are again reasonable.
You got to pick one. I know you're.
I would lean towards osteotomy.
All right.
Hey,
Peter?
little osteotomy in weight bearing straight away changes this guy's life, especially if he's active.
It's a
Low
very-
threshold.
Yeah, it's a very quick thing. Mark?
I think it depends a little bit on activity level, but I think either uni or an osteotomy. If the patient's really active, then I would lean more towards doing an osteotomy.
I'd say until you have bone-to-bone contact, he'll never like a uni here because the elastic-modularity will be too different. He'll have medial knee pain for a long, long time. That tibia has to scleroticize more to support a metal implant. So a uni to me here is a bad operation.
Can we offer him an offloader brace for 3 weeks and then decide?
Yes, so this is what I did. I put a brace on him. But the brace is under his skin. So this is an FDA recently approved implant, which is it's an internal shock absorber, and this was part of the FDA trial. He's 4 years post-op, and he has no pain.
So it's an internal offloader.
Correct. You asked for offloader, I gave you offloader. But I'm a surgeon, not a non-operative conference. Okay, thank you very much. Let's go back to Christian. Thanks, guys.